Welcome all of you to this live program at Orthopedic Principles. Today our guest of honor is Dr. Garcia from Seattle, United States. Dr. Garcia is a board-certified orthopedic surgeon with subspecialty certification in sports medicine and advanced fellowship training in shoulder surgery. Dr. Garcia has a reputation for excellence in sports medicine with over 80 peer-reviewed publications. Dr. Garcia earned his undergraduate degree from Brown University and received his medical degree from the University of Pennsylvania, followed by orthopedic surgery residency at the Hospital for Special Surgery. During his residency, he completed a mini shoulder fellowship in France and then went on to complete a sports medicine and shoulder fellowship at the Rush University in Chicago. Dr. Garcia is actively involved in surgical innovation and works with leading orthopedic companies on the innovation front. His roles include product development, FDA testing, medical consulting, and surgical education. He's also served as assistant team physician for the Chicago Bulls and Chicago White Sox. So today it's my great honor to introduce you to Dr. Garcia from Seattle. Over to you, Grant.
Thank you guys so much. I'm looking forward to being on here. And this is a topic that's near and dear to me from my days at Rush and Hospital Special Surgery. So hope you enjoy the presentation. I think I'm going to begin now. So today we're going to talk about cartilage transplant. What's the hype? You've seen in the news. Again, I'm from Seattle, Washington. I'm part of ProAlliance Orthopedic Surgeons. And these are just a few pictures of the area we live in. All right. So disclosures I can find on the AAOS website. And then special thanks to my mentor, Dr. Brian Cole. A lot of the stuff, a lot of ability to push the envelope, do complex surgeries. Again, we're talking about the cartilage transplants, but we'll talk about how this comes with a lot of other procedures. He was kind of the one that laid the foundation that it was possible, at least seeing that you could do a cartilage practice and be successful. And so I've mimicked a lot of the stuff that I've done based off of learning from him. So cartilage surgery in the news, it's been a pretty big deal over the last year or so. We have the first NHL player, TTO patella cartilage transplant, Gabriel Landskov. And then also another big one was Lonzo Ball for Chicago Bulls. First NBA player, medial meniscus transplant, medial femoral condyle cartilage transplant. So this has become a lot more in my office. Even I've had multiple patients bring these two players up as something that's to the forefront with this procedure. It's been around for a while, but now it's getting a lot more publicity. I've got actually podcasts on my podcast, sportsdoctalk.com, for each of these players to kind of dive into the diagnosis, the treatment, etc. So introduction. So cartilage injury is damage to articular cartilage of synovial joints. It's usually caused by trauma or degenerative conditions. And then really the key here is the symptoms. So it's generally pain, it's swelling, you get limited range of motion and catching. Again, still fairly vague symptoms. So the background. So the cartilage is composed of chondrocytes within an extracellular matrix, and they function really to cushion and smooth the joint surfaces. They have limited capacity for self-repair. Cartilage transplant is you basically take this cartilage tissue from a donor and you use it to restore the damaged area. And generally we use this in young active patients, and we'll get into this in more detail later. So preservation. So the key to preservation, and I learned this from Cole and just my last 7 years of experience, it's really patience. You need to be okay without perfect. We're used to being orthopedic surgeons. We're used to trying to be perfect. These surgeries, you want to do your best. These are very challenging. This is one of the most challenging populations I take care of, but also the most fun. So some of these surgeries, they come with a success rate, not in the 100% like an ACL or 95%. These are 70, 80% success. You can have complications. And we'll talk about that mainly with the concomitant surgeries. Most patients, they don't come in with one surgery. They come in 3, 4, or 5. So if you want to be doing revision surgeries, that's the way you have to deal with the cartilage transplant patients or cartilage patients in general. And the key is it's sort of like a finding mission, right? They come in, they don't tell you what they need, but you got to look outside the box. Do they need revision of their ligaments? What are all the cartilages causing the problem, or is it just one isolated? It matters. You don't want it to be doing surgery on a bunch of MRIs if the patients don't need it. So what is needed to do this? What kind of team do you need? Well, you need a coordinator. I have a scheduler. Cole has his own coordinator. You need someone that's really going to take on this help and help you with the side aspect of it, because securing this tissue and matching the tissue, it's not always easy. So the patients go on a wait list. You wait for the matches. With a cartilage transplant, you about 28 days from finding it, and usually shorter because they've got to do a bunch of tests on it to implant. Now, it depends on your practice volume. I've built my volume up, and now that this is not as necessary, and I can actually pre-book the patients and get the matches on time. But when you first start, you're going to have to do this process. Again, here's the management of cartilage injuries, and we'll get into some of these things later at the bottom right-hand corner. But just because you do the cartilage transplant means you need to be comfortable with other associated procedures. If you're going to be a cartilage preservation surgeon, these things need to be known and you need to feel fairly comfortable with them. Now, it's hard at first, but as you gain knowledge and experience, you can take on all these things: ACLs, revision ACLs, high tibial osteotomy, meniscus transplant, anterior tibial osteotomy, distal femoral osteotomy, TTOs, MPFLs, and the list goes on. So biologics and surgery. So how do we decide? Really, the number one thing is age, but also the willingness to push the envelope. I tell the patients when they come in, there is a lot of different surgeries I can offer you, but you have to be willing and wanting to do this because it's not going to be a short process. We're talking a year, a 2 year, depending if you're staging. What's their physiological age versus their chronological age? Now, again, the data shows it's a little bit, iffy above 50 years old for cartilage transplants, but I will tell you, I've done a number of them in patients who are physiologically younger than 50 years old, and they've done well. Symptoms: are they load symptoms? Are they biologic symptoms? What do they want to improve? They may say, my knee hurts on the inside of my knee, but they have got a patellofemoral defect, right? That's not something you're going to take care of. What do they want to get back to? They want to get back to walking. They want to get back to standing. That's probably not worth it. Do they want to get back to more activities? Maybe worse the risk tolerance. And then what's the risk tolerance? If they have no tolerance for imperfection or any type of absolutely perfect procedure, you don't want to be dealing with this situation. And this is not something you're going to pursue a cartilage surgery on. But again, we're going to talk about all those things, but not every lesion we need to treat. There are so many lesions that I see that I don't treat, even though I do a fair number of cartilage surgeries. So these are just two studies, 2003, 2009. The neglected cartilage patients can do well in the right patient. Again, we'll get into how you pick up when they're going from the good patient that can be neglected to the bad patient that can be neglected. Also, this is a common misconception I see in the city, as I see a lot of second opinions for these types of things. You don't always have to intervene with a cartilage defect in ACLs. This is a study, 2015 AJSM, 644 patients, ACL tears and a full thickness cartilage defect. There were 129 debrided, 164 microfractured, 2-year follow-up. The microfracture group did significantly worse on KOO scores and pain scores. And really the conclusion here was ACLs, microfractures are negative outcomes, but if you just do debridement, there's no negative outcome. And in these patients, you can always go back and do a cartilage surgery 6 months to a year later. I've had a number of these even in the last year or two that I've dealt with, but you don't want to give them this negative outcome right from the beginning. So who do we treat then if we're going to talk about these people we don't treat? It's all about symptoms. It's not about MRI findings. Most of the time, it's about symptoms. Remember, they're subtle: swelling, pain, locking, catching. Many times you just get the first two, swelling and pain. Damage secondary part to meniscus or tibia. If they're starting to develop tibial damage, they're starting to develop meniscal damage, you want to probably consider intervening. And the skill here and the expertise here is finding the fine balance and getting them right before they hit the tipping point. That image on the bottom right is not an ideal situation. You have a cartilage defect and now completely gone meniscus with looks like mostly intact tibial plateau. That's a problem. So index scope. So all patients in my practice get a diagnostic scope. And I really don't rely on all MRIs or old scopes, and patients come in for second opinions having had a scope. And a lot of times I make them do it again, especially if it's more than a year old. You really want to avoid the bail during surgery. It also helps improve insurance approval. Again, not the main reason that I do it, but again, we want to find different additions to help us get these patients taken care of. It allows me to set further expectations. You can see here, we have an image on the top right that shows like the joint space doesn't look that bad, but you get in there, that's something you're not going to do a cartilage surgery on. Maybe you're going to talk about something else, but not the cartilage surgery. We often find other issues and can expand the surgery. The number of patients I go in thinking I'm just going to need to do a cartilage transplant and I need to do a meniscus transplant in addition is fairly high. And the other way around, a lot of meniscus transplant patients have cartilage defects that are not visible. So the lack of scope can lead to unexpected problems. Again, probably 80% of your patients, you're fine, but you don't want that 20%. That's a bad day in the operating room. So again, how do you talk about the two surgeries? It can be a challenge. You have patients as a second opinion, third opinion doctor. I see people in the city that come in there like, my surgeon didn't want to do a scope. I don't really know why you need to do a first scope. So there is some discussion points that come in there. Again, not all the time, but it's something to discuss. So how do you talk about two surgeries? There's some benefit to the scope itself, I tell patients. You're removing the edges. We'll get into that in a second. There's really not always, if you don't have enough good index information, if you're like, hey, listen, there's something here, I'm not feeling it, there's a small defect. I mean, you can look at this image on the right. It doesn't look that bad. You get in there, it's full thickness. That cartilage is of bad quality. So it helps you set expectations. A lot of times patients come in, you've got a lot of information, you know fairly certainly what they need, but you can now finalize it by this scope and say, hey, look, here's what you need to do, here are the steps. And a lot of times the patients actually feel much more comfortable with the procedure after the initial one. And again, the initial one's usually fairly easy recovery. You have to be patient with these patients. They're more complicated. Generally, if you're a cartilage surgeon in the city or in an area, people are coming in from far away to see you because it's a less commonly done procedure. So these patients have spent a lot of time and effort to come and see you. And in my case, it can be hour, 2 hours, 3 hours, or flying from out of state. They don't want a 2-minute visit like you would maybe for an ACL tear. So why would you ever intervene? If we've talked about some of these things, you can leave them alone. Well, here's a good study from KSSTA, 2019. 32 patients all had cartilage defects. 16 had cartilage treatment, 16 non-op. Again, defect size about 1.4 centimeters. Half were patella, half were condylar. Follow-up was about 6 years, so not even that long of follow-up. The non-op group did significantly worse scores with more severe OA. So patients, again, with cartilage repair show less progression of OA compared to non-op with identical cartilage defects. Now, again, I don't tout that I'm going to reduce, they're never going to get arthritis, but am I going to slow the progression? And that's the key. So here's my algorithm. Again, it's very detailed, along. Generally lean towards debridement most of the time in the initial setting, especially in the in-season athlete. Microfracture, we're doing a lot less of this. We have some smaller procedures like autocart, biocartilage, autograft transplants, again, for these small defects. And then workhorses are MACI, usually for patellofemoral lesions. Again, without cysts, if there's bone issues or cysts, we're leaning towards cartilage transplants. And then the large defects, meniscus transplants in combination, I like to do the cartilage transplant. So what I think about, well, how does this all relate? Physical exam, history, MRI, alignment, you got to piece it all together. All of these things are important. You see here on the right-hand side. You need to be aware of all these things to get the best results. The number of second opinion patients I have seen that have had a cartilage surgery that did not work, or the doctors say the cartilage surgeries don't work because they skipped other steps in this circle, is a problem. And it will fail. I've seen patients that have had meniscus transplants that didn't get realigned. I've seen patients that didn't get TTOs with cartilage transplants, and those patients failed because they weren't properly, everything in the environment of the knee was not properly set. So what's the issue? Well, most surgeons don't review all, and it's not because they don't want to. It's because, one, training. It's very difficult sometimes to get training with high volume cartilage surgeries. There's only a handful of places in the country that do this. Again, it's time consuming. These patients take much more time in the office. Even if they come in with an MRI, they know what they have. You have to have a long conversation with them. And many of the problems require multiple surgeries. So you're not just telling them, okay, here's what you need. Here's the next step. Here's the next step. And if you're not a hub for cartilage surgery, your volume can be quite low. So if you see one of these a year, it can be really difficult to take on something very challenging like this. And then the more previous surgeries, the worse the outcome as well. So understanding that if a person comes in with 7 or 8 surgeries on their knee, their outcome's not going to be the same as that person with the initial OCD, and you're going to do a cartilage transplant now on them. So again, just reiterating, you need to check everything. It's like a 3-legged stool. Alignment's key, instability, and meniscal deficiency. It's not just the sexy cartilage transplant. So there's a spectrum of treatment here. You go from the most common, as you can see, most people do a lot of debridement, microfracture, and then you're breaking it down to a very low number of the more precise and more advanced cartilage surgeries. And there are some new ones out there that are not on this list. So again, debridement can work. I have had patients I have debrided that have not gone on to cartilage surgery. So again, eval lesion, again, it's always bigger than you think. It's always bigger. Sometimes debridement alone can treat the symptoms. You don't always need to microfracture these. And debriding these focal defects and you leave this sort of bevel, it can decrease the contact surface area. And patients can do well even for a short period of time. It can buy them time so they can process what the bigger surgery they need. Chondroplasties can work in even athletes. So 52 athletes, follow-up 5.9 years. There was no correlation with the age, the lesion size, the location. Now, prior microfracture, again, microfracture is falling out of favor. I do very, very few microfractures. 4.4 times less likely to return to play. 67% return to play in the NFL at 8.2 months with an isolated chondroplasty. So that's fairly good for all very high level athletes that are doing high impact. So the cartilage transplant procurement process is interesting. It's good if you do these to know how it works. Again, there are some newer sort of techniques that possibly you can procure it for longer, but generally you get this within 24 hours of asystole for the donor. Aseptic processing. Patients always ask, in most of the cases, you're doing 2 rounds of testing, bacterial and PCR. They check for all sort of diseases, and now actually COVID. There's sort of prolonged fresh options as well. And the goal is 28 days to implant. You can see from the study that the chondrocyte overall, the chondrocyte viability is really at that we don't want to push the envelope past 28 days. Matching. So we used to do x-rays. We do those sometimes, but really most of it's MRI to match. The companies have proprietary matching software. Trochlea is a challenge. It's very hard to get a well-matched trochlea, even if you go through the companies that have really highly sophisticated cases. Now, there's certain 3D mapping programs that people have talked about, but overall, you really need to look at these graphs. You can see a picture of them on the right-hand side. That's how we get them. So you can use these trochleas and say, hey, you look at your MRI, compare it to what you see in the match, and you can kind of know if that's a good option for you. But a lot of times, you just have to get creative when you're making these graphs. And you can do a really good job with trochleas. It's just you need to be prepared for a little bit more effort. Again, you submit the MRI, you submit for insurance approval, and then eventually the graft company will send you a match. This is usually what it looks like on the bottom right or the bottom side. And then you have 28 days. You can see there's an expiration date, the release date. So this is a long period of time. Sometimes you only have 2 or 3 weeks. So if your patient's been pre-scheduled and you get the match, usually you can go ahead, or you have to move things around in your schedule to get them done. So this is just a brief video. We're not going to go into too much crazy detail. Now, this patient actually, you can see in the back, there's some needles and sutures. So this patient actually was getting a meniscus and a cartilage transplant. We don't have time to go through all that today, but maybe in the future we can talk about it and really the timing, how you do it. So you can see here, we're going to line this up. And then we use a chamfer. And the chamfer I like because you haven't made the coring, you haven't set this yet. So you can see whether or not it's going to fill the whole defect. Now, again, we're going to ream this out. Generally, we go between 6 to 8 millimeters. If you have a really deep OCD, sometimes you'll go to 10, but usually the data shows 5, 6, 7 is really good. Then we're going to kind of mark. Again, the key here is you want to make sure that you use the mark is for the 12 o'clock position. We're going to core this out. Again, we're putting fluid on this because you don't want to burn the tissue. There's some data showing potentially doing this with iodine to try to reduce the chondrocyte damage. We're going to core this out. And then we're going to take the plug out, and now you have this separate plug. Now make sure you go deep enough so that you can take a little bit more off if you need to. And then I usually measure 4 quadrants. I find that if you're really precise with this, 4 quadrants enough. You do not need to measure 6, 8 quadrants. Usually 12 o'clock, 3 o'clock, 9 o'clock, and 6 o'clock. And now what we're going to do is we're going to mark this out. And then we're going to use this sort of proprietary grabber. And then we're going to use a TPS saw. Now, I like to use TPS most of the time. There was a larger saw there. And then again, you want to really round these edges because sometimes it can be hard to get the transplant started. And so if you round the edges, it makes it easier to put in there. And then what we're going to do is double check this with a ruler. I usually like the paper ruler. It's a lot more precise. You can really see the numbers. And then we're going to do pulse lavage. Now, not shown here is I actually use a sort of CO2 jet as well to take out some of the marrow elements. Some of the data is shown that's quite helpful. And then you can see here that most of the time you can actually plug most of it in. Now, this is very light taps. It's hard to tell how hard I'm hitting it, but you really don't want to be hitting this hard. The trick here is you can see that I've already pre-contoured this. So I got it from the same area of the condyle, and that really fits nicely. And you can run that along to make sure that it's smooth. So again, we're jumping around a lot, but these patellofemoral cartilage transplant patients is a different animal. So you may have to do a TTO. You need to think about alignment. If you've got a cartilage restoration patient with a defect laterally versus a defect centrally, your TTO angle matters and how you're going to do it. Instability as well. It depends on the TTTG or TTPCL and your CD ratio. So all those things come into play, and I love these arthroscopy color outlines. So what are the results of these transplants? So return to athletic activity. Again, older study, we're going to go from older to newer. So 43 patients, 74% recreational, 23% collegiate, 2% pro. They excluded the HTO and the DFO patients, mean age 33, 58% prior surgery. You can see that they had pretty high return to play, 88%. Return to previous levels, 79%. Average return to sport, 9.6 months. That's really important for you to people to hear. Lower return to play over 25 years old or more than 12 months of symptoms. So how about 2017? So 149 E's. This is from a high volume surgeon. 45% were highly competitive and 55% were well trained. Mean follow-up was 6 years. 75% return to play, 91% satisfaction. This can be a very high satisfaction procedure. Again, key here is graft survivorship because that's what patients are going to ask. 91% at 5 years, 89% at 10 years. This is really, really good data for patients that really, when they get these defects, if you don't intervene, they can go on quite poorly to a bad outcome. Now, the additional surgery is something to consider. Now, you can see here, these are all the things that can happen afterwards. So it's really important to understand that this patient may be a patient for life. Can competitive athletes return to high level play? Again, 2017, small number of patients, 13, but we love these return to sports studies. 5.9 year follow-up, 77% return to play. The key here is not all of them went back because of a problem. 50% of them graduated from their high level of sport, and 38% were fearful of re-injury. The mental aspect of this is humongous, especially with these larger procedures. Generally, it's not their first surgery. There's a lot going on, and you're telling them they need a year or 2 years of recovery. There is a lot of mental stuff that you're working through them. I say that I spend a little of my time as a sports psychologist in the office because of what we're dealing with. So return to sport here was 7.9 months, 3 reoperations with no graft failures. So another return to sport. This one I really like because it really goes over all the different types of cartilage surgeries, again, that were available in 2016. And so there are more ones out there now. So 44 studies, a very large patient population, 76% return to sport. For autografts, 93%, one of the highest returns. Again, though, leaning towards the fact these probably also had smaller defects. Cartilage transplant from allograft, 88%. ACI, also known as MACI now. Again, a lot of these were used for patellofemoral in this study, 82%. And again, microfracture, really not a great surgery, 58%. You can see return to sport. If you're going to have a 58% return to sport with a 9-month recovery, that's a real problem because it's the same as some of these more advanced cartilage surgeries. So why not just do those first? You have OCA and ACI was a little bit longer. And in my experience, those tend to be some of the longer recoveries for the MACI. So how about outcomes in general and more survivorship? So again, another large systematic review. Mean age was 37 years old. Again, we've seen some younger patient populations, but generally these patients, they can range in my practice from that sort of 20-year-old to 50-year-old range. And 37 is about the sweet spot. The etiology or pathology is 37% post-traumatic, 30% OCD. You have AVN, idiopathic. Again, what's really the key here is this is sort of the number I give them, and we've seen better numbers, but sort of they really care more about the 10-year data of the patients or the 15-year data. So 76%, 10 years, 15 years are still intact, 85% at 10 years, and the gross et al. So another one, 2021. So we're getting newer, getting more advanced techniques using biologics in addition. So 160 patients, 7.7 years of follow-up. Mean age 31.9. Again, Brian Cole. A lot of these are from the same institution. They're at Scripps, they're at Rush, they're at HSS. So results: reoperation 39.4%. Again, more surgeries are sometimes needed. Survival rates 86% and 81%, 5 and 10 years. So high BMI. This is a really important one. Longer symptoms in previous surgery were predictors of failure. Now, athletes actually had a decreased chance of failure. In general, my experience is high-level athletes, when they get this, they actually can tolerate any sort of slight decrease in the quality of their knee more than a patient that's generally a recreational. So this is an important aspect to think about. So let's add a little bit of flavor to this. What about if you do it with a meniscus transplant? So there were 2 groups: meniscus transplants with no defects and meniscus transplant with a focal cartilage defect, which we originally had always been told, if you got a meniscus transplant and there's a cartilage defect, they're not going to do well. Well, if you treat this, they actually do just as well. So all patients were treated at the time of a meniscus transplant. So concomitant, this is really important. There's a number of meniscus transplants I do with cartilage transplant is quite high. And so 91 patients, 22 had no defect, 69 had defect. Again, people you're doing meniscus transplant without a cartilage defect, you have to think about it. Again, it's a lot less common. Your practice should not be made of isolated meniscus transplants because you're probably missing the cartilage aspect. Mean follow-up, 4.48 years. Mean defect size, these are pretty large, 4.43. No difference in failure rates, reoperation, or overall scores. As long as you address the defect At the time of the meniscus transplant, the results will mirror an isolated meniscus transplant. So this is really important to know. If you do them together, they do quite well. And this has been my experience. Again, another study, similar patient population. This is now flipping the lid. This is saying, how about a cartilage transplant patient isolation versus a cartilage and meniscus? How do they do? So 100 patients, 50 were isolated cartilage, 50 were cartilage and meniscus transplant. 31 years roughly, similar to the same other group, 4.9 years follow-up. Most common were medial femoral condyle. No difference in failure rates or reoperation rates. The survival rate was overall pretty good as well. Now, again, not as long a follow-up as the other ones, but 86% at 5 years, 86% for the combo at 3.14 years. So there might be a little bit of a dip in the patients without cartilage and meniscus, but it was not statistically significant. So 2018, so this is, how about it with ACLs? Because we were just talking originally, when do you intervene? So the patients that you intervene with that have symptoms after the cartilage injury, if you did breed it or something else, or you decide you're going to take care of it because it's a pretty deep defect, 31 knees with ACL and cartilage transplant versus 62 knees with isolated cartilage transplant. The failure rate was 9.7% in both groups. Survivorship, 94 and 82% at 5 to 10 years versus the isolated OCAs were about the same at 93 and 79%. Similar satisfaction. So combined together, do very well and actually do just as well as cartilage transplant. So remember, you have to address everything. And if you do it, to be honest with you, some of my happiest patients are my ACL combo with cartilage and meniscus transplant at the same time, because they're doing so poorly beforehand. And I would tell you the results, my results mimic this, and this is what I have seen in practice. How about as a salvage procedure? So now we're getting into the newer and newer studies. This is 2025 AJSM, 6 studies, 350 patients. They had failed their index cartilage surgery. And again, a lot of the times, this is what I used cartilage transplant for. So OCA used a 16.6% failure rate, but a 42.8% reoperation rate. So that's important. The defect sizes were quite large, and they were 39% failures and 67% reoperation for those previous patients. 5-year survival, 79 to 87%. 10-year survival, 61 to 82%. Most outcomes significantly improved post-op. Again, you can see here what the previous cartilage surgeries were. A lot of times in my practice, I agree with this, sort of the marrow simulation, but there were some revision transplants. We'll get into that in a minute. And you can see their sort of the gist of their practice. Again, I have a high patellofemoral practice, so my numbers will look a little different from the cartilage location. But cartilage transplant is a valuable option after previous cartilage repair and should be really high on your list when you see a patient like this. So midterm survivorship, clinical outcomes. Again, this is a tough patient population. Bipolar lesions, generally challenging to get actually approved from insurance, but something to consider. So 89 knees were treated with bipolar lesions. This is a very difficult patient population. The mean defect size was quite large at 16.7 centimeters squared. Mean age slightly older, 37.9. There were 43.8% were patellofemoral, 22% medial, 27% lateral. 91% had previous surgery, which I'm not surprised with. Graft failure rates, 34.8%. That does seem high, but actually this is a very difficult population. If you can do anything for them to avoid a knee replacement or a partial knee replacement, this is really success. This can be as high success for this type of patient population. 51.7% time to failure was 4.8 years. And you can see 73.8% at 5 years, 66% at 10 years, and 58.9% at 15 years. If you imagine this, these patients were really, really poorly off. Like, this is a really bad situation that you're going on to a partial knee replacement. So the fact that 58.9% avoided a knee replacement at 15 years is very impressive. So good results for a challenging problem, and I commend them for this. So risk factors for failure after cartilage transplant. So here's a meta-analysis, 1,400 patients, again, still quite new, 2023, 18.9%. Significant risk factors, bipolar lesions. We just talked about how hard that patient population was. Male sex, older age, higher BMI. So these are all things that you want to consider and talk to the patients about as being a higher risk. There's some findings that defect size, location, common procedures may be there, but they're really not significant. So again, it depends on a personalized factor. You have to tell them, like, here's you're over 50 or you're 45, your BMI is on the cutoff. There's certain things. Now, my BMI cutoff is 35. I will not operate for the most part above 35 with BMI because I do not want this is a pretty large factor, and there's a number of studies that have shown that. So comparison. So how do revision cartilage transplants? Again, if you're not high volume, you may not see one of these. They're not that common, but overall revision versus primary and what are their outcomes? So 15 revision versus 30 primary. This is AJSM 2025, very recent. So 9.3-year follow-up. Most common concomitant surgery was meniscus transplant or osteotomy, and I would agree with this. This is what I see. 73% of these revision patients actually had concomitant surgery. High patient satisfaction. There was really no difference. I mean, there was a low overall failure rate was a little bit lower at 13% versus 20%. You can see the Kaplan-Meier on the right side, but it was not significant. So to be honest with you, revision transplants by this study do pretty much as well as primaries. So it's something to consider that you shouldn't bail on that. I have a recent testimony I'll be posting of a patient who had a third time patella transplant. So again, you can get away with it, but again, it's a population you need to be aware of. There's a lot of other risks involved with those situations. So how about outcome of revision cartilage restoration? So after failed again, this is another new study, 2025, systematic review, 16 studies, 1,300 patients, 20% failure rate for revision. Most frequent revision is had a patient had a previous ACI. So you can see the overall failure percentage of those different groups. The revision with the OCA. So if you revise with an OCA versus an ACI, the success rate was about 19% failures versus 35%. Reoperation rate, 40%. So it's still not, like I said before, this is not a low risk population, low risk procedure. Patients do well. Most of the time, these reoperations, they're chondroplasties or small meniscectomies. So again, it's a pretty low complication profile, but it still happens. And again, revisions remain challenging. OCA in this study showed better outcomes than revision ACI, and I've seen this in my practice as well, even though I do a fair amount of MACI as well. So getting to the final slides, really the key here is dealing with complications, or how do you reduce them? So graft loosening, press fit technology, you really want to try to consider press fit. Make sure you always have some sort of biocompression screw on backup. It's infrequent that you'll need it, but at 7 years of doing this, I've done only had to do a handful, but it can happen. And so you want to make sure you have it always in the room with you. Allograft fragmentation, obviously hitting the mallet too hard, you can damage the plug. You really don't want to be hitting it that hard. You really want to taper the edges. You really want to do a lot of dilation, especially with patella transplants. Graft overload. This is a common mistake for new surgeons or surgeons with low volume. You want to obtain long leg x-rays. You want to check for malalignment. You want to make sure that you don't skip and say, I'll take a lateral condyle, I'll take a patella, I'll do a medial condyle with it. You want to match same to same and be really strict about it. It will pay off in the end. And make sure you orient the grafts properly. You can see on that one video I showed that that inside the notch of the medial condyle is a challenging area to contour. So if you take it from the exact side and you get a condyle, you can match it quite well. And I find the condyles are a little bit easier to match, even the patellas, or definitely different than the trochleas. And then this sort of non-union collapse. This is one of the ones you don't want to see. It obviously is frustrating. It can happen to anybody. But you consider biologics. We talk about PRP or BMAC. We didn't have time to go in that today. I really try to drill this sort of bony bed to reduce that risk. And you really want to reduce the impact activities. Even though the patients usually feel pretty good by 3 months, they're not ready to go back to sport. Thank you.
Thank you, Grant. Grant, you can stop sharing.
All right.
You can close it.
Stop sharing.
Yeah.
Perfect.
Cool. Grant, thank you for this comprehensive presentation. You've covered the entire gamut of cartilage surgery.
Thanks.
But it was good. I mean, it's a great archive. I'm sure it's going to benefit a lot of people. And Grant, let's have a short Q&A. Grant, of particular concern is the biocartilage versus autocart. You mentioned, right? Our smaller lesions. Now,
Yeah.
autocart is nothing but minced cartilage, right? Autocart
Correct.
is cartilage. So I remember Kevin Stone from the Bay Area used to talk about it 15 years ago, and he has a lot of publications as well. And in between, no one talked about minced cartilage, and now you're back. So do we have level 1 data to say that, okay, minced cartilage is equal or gives non-inferior results compared to other methods of treatment?
Well, I think they're working on that. I mean, I work with some of the companies that do some of this stuff. Like the key here is to look at more comparative data. I think the goal here is going to be compared to something like an ACI, right? Where you've got sort of, you take the person's cartilage and then you build it back up. It's still not there yet where we have level 1. But at the same point, remember, we're trying to work towards these are smaller defects, right? It's a little bit less common. It's kind of has to fill this niche, right? For these massive defects, we're generally not doing these large. We're not doing the other procedures like that, and we're usually sticking with more of the ones that are the time tested. But nonetheless, there are plenty of case reports and data showing this, but we're not there yet with the level 1. But we're getting there, and I think the key is trying to figure out what other things can we throw at the plate? Because when you hear these cartilage talks, they're generally cartilage transplant or MACI, and we would love to have other options, and we're working towards them, but we're still not there yet.
Thank you, Grant. And Grant, about autologous chondrocyte implantation, right? And that is great because you have the patient's own cartilage cells that grow, right? So I was talking to some of the surgeons in the UK, and they found the logistics was the biggest issue with ACI. Taking the biopsy, sending it for culture, and getting it at the right time to re-blood. For example, some of the centers that I spoke to, they were sending it to actually Germany. They don't have the center for culture there. They're sending it to Germany and getting it done and transport back and re-implant at the right time. So do you face similar issues in Seattle, or is it easily to get the culture done?
Yeah, so I actually work with MACI a lot as one of my disclosures. I do a similar number of MACIs as I do of cartilage transplants, and I've had similar talks on them. So we don't have the same constraints because of the MACI company. Vericel is so big, and we send ours to Boston. So at probably almost similar distance to going between the areas. We don't tend to have an issue with it, but again, the way that it's laid out as a pharmaceutical, it's usually approved from the insurance aspect. They have a pretty big team that they work with. So we're able to get it done. And generally once the biopsy's taken, it sits there. But once they get up, they don't build or make the cartilage for you unless the insurance has authorized it. So it's a little different than maybe in the UK or Germany. Again, I don't have this experience in the European aspect of things. But again, there's certain things that we have first that they can't get, like we do arthroscopic assisted MACIs now, and they're not there yet, I think, because they're working on the approval. The approval process has actually changed, where actually the US is easier than the European, which is opposite of what it used to be.
And once you procure it, once you get it back, is there a time frame? Okay, once you get it back, within so many hours or within so many days, you need to reimplant it.
Yeah, so usually they say 14-ish days or less, but to be honest with you, you don't usually procure it until the insurance is authorized and the patient is scheduled for surgery. So, but one caveat is, like, we get snowstorms here, right? Or thunderstorms or rainstorms anywhere in the US, but Seattle's known for, if they get snow, the entire place shuts down. So if you get that, it's always good to take extra biopsies. So when we do our biopsies, I always make sure that I have at least enough for 2 or 3 procurements, because I've had patients that have had to cancel their surgery last minute. And once that's thing grown, they can't go put it back in the biopsy kit. So you want to make sure you have backup. But generally, they're not sending out or making it until everything's ready to go.
Thank you, Grant. Just one last question, Grant. Now, Grant, cartilage surgeries have grown really great. I'm sure you worked with Professor Cole, and I'm sure this presentation is, it's rich. And one of the concerns is picking up these cartilage lesions prior to surgery, right? You get the MR done, and are you able to pick those cartilage lesions, and especially the size? Are you able to determine them before the surgery? The advances in MR, for example, you have an advanced MR, the degeneric MR or T1 row mapping, and or do you end up doing a diagnostic scope, find out the size, and then schedule for another surgery? Are you able to do it in a single sitting most of the time, especially with transplants?
I'll tell you with experience, yes. I pretty much know what they're going to get for the most part, but every once in a while you get surprised. A couple of weeks ago, I was doing a meniscus cartilage transplant. And I remember scoping the guy 2 months ago or 3 months ago, and it was going to be a single circle. And I got in there and needed a snowman. So it was almost double the size. So it even shaved off more. But a lot of times I can predict what they need. But to be honest with you, you probably saw the size of that defect versus the transplant that I got. You have a lot of, by doing that, you protect yourself, because every once in a while you need to go do an extra one. If you find something that even happens between the index surgery and that time. But I find that with the new MRIs, I'm able to predict. But again, I always assume it's bigger. And that's generally right. Usually I would say it's about 50% bigger. Again, I don't have the data on that. But in my experience, those edges are loose that you see on the MRI. And so yes, with all the mapping data and all those things, it can be really nice to predict it. But also what's really hard is unless you're at a really high level academic center, those MRIs are hard to get sometimes. So it just depends on the situation.
Thank you, Grant. Grant, I think that's all the questions that we have for this session. Thank you for this wonderful talk and really look forward for more in future.
Thank you.
Bye-bye.